Hi, everybody. Welcome to Beyond Telehealth. And my name is Dr. Lisa Finkelstein. We have a special edition tonight. We have two brothers who are physicians, and one is older. I'm not going to say which one is older, but we have Dr. Richard Domsky and Dr. Marc Domsky. One of them also has a secret, and we're going to find out what that is at the end. So let's start with Dr. Richard Domsky. If you could introduce yourself and tell us what your specialty is and where you practice.
Sure. My name's Dr. Richard Domsky. I'll admit it, I'm 64 years old. Reaching the zenith of my career soon. I am practicing in southern New Jersey near Atlantic City, where people out west might not know where, near Atlantic City where the casinos are. We have about 5 offices in South Jersey, right outside of Philadelphia, all the way down to the southern part of New Jersey near Atlantic City, where I'm the director of an office that has 2 physicians and 2 nurse practitioners and a whole host of employees. I'm a pain management physician as well as board certified in both pain management and anesthesia. I both practice in academia as well as private practice. Presently, I'm in a private practice, and we have been using telehealth or telemed since the pandemic started in probably March, little after March 20th.
Perfect. Wait, let's go to your brother.
Sure.
Dr. Marc Domsky, and if you could introduce yourself, tell us what your specialty is and where you practice.
Sure.
And one more thing, guys. We're supposed to have 5 minutes with Fink, but we're going to say 10 minutes because there's 2 of you guys. So go ahead.
Okay. I'll try to speak fast. My name is Marc Domsky. I am Richard's brother, and I'm 60. I'm not quite at the zenith, but I'm getting pretty close to the zenith of my career. I practice in Jackson, Wyoming, at a small hospital, about 50 beds. I'm a board certified anesthesiologist. I did a fellowship in critical care medicine. I have a master's in business administration, and I've always had an interest in pain. I have been, since I was a resident, is when I first developed an interest in pain management, more post-operative. So it was more on the acute side than the chronic. But I did some research back then with intrathecal narcotics, which is spinal narcotics, where instead of taking Percocet, you inject a little morphine in the cerebral spinal fluid, and it can give you profound analgesia.
Okay, guys. So this is about telemedicine, and we know that telemedicine is medicine. Richard, were you using telemedicine in your practice prior to the pandemic? You alluded to that in your introduction.
As I stated, I've known Lisa all her married life, and they've been asking me to get involved with telemed, but we were not using it. We were aware of people. And as soon as this pandemic started, we initiated the use of Zoom right away. Basically, it was all over the internet, and how to use it. It took a couple of days. There is a learning curve. It takes a few days to initiate your practice as a physician and a nurse practitioners, how to get it customized, how to train your patients, how to educate your patients, and how to educate your staff so that you can ascertain the process and actually make it run smoothly. Presently, I only work 4 days a week. As I said, I'm reaching your retirement. So 2 days a week, Wednesdays and Thursdays, I do remote telemed. Mondays and Tuesdays, I'm in the office. There are times during that office hours where I do a telemed consultation or a visit.
But you try to schedule them back to back to back to be efficient.
Correct. So on a regular day where I'm doing remote, such as today, which is Wednesday, I saw 35 patients through telemed using Zoom telemed conference. And it went very, very smoothly. Usually I mean, I'll stop and let Mark explain how he does.
You have them all to screen at once?
I
Hollywood Square.
I do do it. I do check all my.
Your turn.
There's no problem with the process, but I would be also, it's another question is what EHR I use. I use Experience. It doesn't have a self telemed system. Other systems such as Epic and a couple of the other ones that I've used before in my other practices, they all have the self-contained telemed unit that's associated with it. Ours does not. So that's why we chose to use Zoom.
Okay. All right. Let's have Dr. Marc Domsky tell us what were you using telemedicine prior? What platform are you using now, and what EHR?
I would say prior we were using the old school telemedicine, which was the telephone. Patients would call, leave messages, you would call them back, discuss things. With the introduction of telemedicine, it's kind of changed that habit a bit. And ultimately, we started with the pandemic, when the pandemic started, and our platform is a HIPAA-compliant Zoom license. I have that through the state of Wyoming, which is a great benefit of living in Wyoming, one of the many benefits, or some would say maybe one of the few benefits, but it has been exceptional. So because of the pandemic, I mean, we still had to see patients, and it's been a lot of fun as far as the logistics of it and how we use it. To me, with the staff, I walk into the room, there's either a patient sitting there or the computer sitting there with the patient on the screen. So it's very efficient. There really hasn't been any change in the flow. I mean, it's obviously much more efficient for the patients, which is wonderful, so that they don't have to drive. In Wyoming, sometimes people have to drive 2-3 hours to just have a conversation. This way, we can have that conversation on Zoom.
So it's interesting because initially telemedicine, the paradigm was about being in a rural state. And I've always thought, and this is a great example. So, Mark lives in Wyoming, Richard lives in New Jersey. They both practice pain management. And yet it's really good for both situations. So it's good for people that can't get to you driving through a blizzard. But Richard, you were saying that you have a percentage of your population that has difficulty getting to you even in somewhat of an urban area.
Correct. We have a patient population that starts from people who live in a motel or hotel, indigent, Medicaid, Obamacare, right up to a CEO of a large corporation. So we see a multitude of patients. Some of these patients don't have internet access. Some people live in their car. I know it sounds silly. Some people live in a motel or hotel, and other people have full internet access. Some of the problems that you will run into, or that we run into, some people, a majority of the indigent don't have internet access, nor do they have a correct smartphone, which you need, or access to a computer or a tablet or some sort of access to the internet itself.
Or so even an email for that.
Correct. That. They don't have an email. So whatever platform you're using, you have to have access to the internet and email and having a smartphone. So I'd say probably a little less than 50% of our patients we were able to connect with. And the other way, as Mark said previously, we use the old way, telemedicine through the phone. So we are dialing up, calling the patient. All our patients are booked by, we have a communication center, a booking staff at every one of our offices. So these appointments are all set up with our staffing starting at 8 o'clock to 3:45. So it's approximately 35 slots, and they're all booked. And then what will happen is on my platform or my EHR, the names roll in. All I have to do is check them in when I'm doing it remotely. Right. Obviously, when I'm in the office, they're checked in by the staff themselves. But remotely, I check them in. So I get up earlier. The process, if you want to be efficient, you have to get up and be prepared. There is a learning curve to this process. It's not very, very difficult.
So, Richard, you see your patients telemedicine predominantly at home. And then, Mark, you see your telemedicine patients at the hospital in your office.
Yeah, in the outpatient surgery center.
Right. So,
yeah.
Okay, let me switch to a different question. So, because we're running out of time, guys, it's at 10 minutes. So we have two more questions. One is will you continue using telemedicine after the public health emergency happens? So, and then you can talk in that about getting paid for telemedicine and how that would determine your decision. So let Marc go first, and then Richard, you finish.
Okay. Absolutely. I mean, I think it's, when we were, I'll try to make it quick. Going through medical school, they used to tell us the history and physical is the most important. What you learn with experience over the years is the history is important. The physical is kind of important. And I think the beauty of the pandemic is it has borne that out with telemedicine. When you can see the patient, you can still do examinations and have patients do various maneuvers to elicit problems and help you see what is going on via, the video platforms. I just think it's a great mechanism for care to be delivered to people and just make it more efficient for them as well as us. Healthcare shouldn't be a burden. It shouldn't have to take all day to have an appointment to see a physician. And this is also going to allow improved accessibility for people, as Dr. Finkelstein spoke about, with bad weather, or as Dr. Domsky spoke about, Richard, that Dr. Domsky, who have difficult living situations. And I think it's a mechanism to address the social determinants of health, which is important and it's hard to do when someone has to show up with your office. When you can see the living situation that someone's in, it already helps you get an idea of a component of what their pain may be coming from. So we'll continue to do it, and we do get paid. Right now, we are at the way the insurance companies work and the policies. We're kept at what's called full parity, where we're paid the same whether they come into the office or they live, or we talk to them via a video platform. And I think we'll continue to do it because depending on the time, whether we get paid or not, we used to answer the calls, as frustrating as it could be. I freely say that. But this way, at least you can see what's going on as opposed to just talking to someone.
All right, Dr. Richard Domsky.
Presently, we are getting paid in the state of New Jersey while the pandemic is going on. So I'd say I can't tell you if it's full parity, but we are definitely getting reimbursed for all our patients. There must be an incentive. We will continue to use it, especially for patients who are immunocompromised, who have to come in by medical transport, which we see quite a few of those patients. We're not in a remote area. We're very urban, and we'll continue to do it. The question is, what happens when the pandemic is over? And I am surely not like President Trump or the old Vice President Biden. I have no, I'm not a soothsayer. I have no idea when this is going to end. But I can see that it's going to go on for another year or so. So we'll continue to do this telemed. And it's very helpful. And, we're getting paid for it. It's very efficient. It's great for the patients. It makes it a lot easier. And, we will, as I said, we'll continue doing it.
Great. Well, this is the secret.
This is what's great about telemedicine. Dr. Richard Domsky has known Dr. Finkelstein as long as she's been married.
So, Richard, give us a funny story, a funny telemedicine story. Let's leave with that.
Well, so as I stated before, we started this in middle of March, and it was very new to us, very new to me, and I have a good sense of humor, which I obviously don't have time to show you or express, but the patients also have an incredible sense of humor. So I would say in the first few days when we started it, we were not in the office at all. We were doing remote the whole time through March through probably till May, and then we came back into the office a couple of days a week with my partners. That you would, see these patients. They didn't realize that we have access to everywhere. So they would take their phone or their laptop or their tablet. They'd be in the bathroom. They'd be in the shower. They'd be smoking a cigarette in bed. As Marc said, these are the type of patients you see their lifestyle. So it really shouldn't bias how you treat the patient, but it was kind of, quite comical to see them like that.
It's a whole different.
I was always in my office, or I'd be in my little office in my home right now. So I never really disappeared. I definitely have. I adopted a puppy from this pandemic, so he comes in and out, and now all my patients know who my dog is. He comes to the office, so that's about the funniest thing. Or when they answer
behind you, Richard.
Murray, this is Murray. Come here, you knucklehead. Right here. This is Murray.
Mary practices telemedicine with Dr.
He's a telemedicine dog.
He's a telemedicine dog.
I mean, it's a different type of connection you make with patients on via telemedicine than personally.
It's a lot, right? Correct. It's actually, I think it's more open, and you can discuss things that you normally wouldn't discuss. Right. And when you find out about patients and things like that.
Yeah, I agree.
All right, guys. Well, we have some comments from the family here. Let's see. What is Chris saying?
He wants to know how we diagnose.
Since the start of the pandemic, you've both exercised the use of telemedicine extensively. This requires an accurate, valid, and extensive digital health history of your patient in order to best diagnose and treat. How has reliance solely on an EHR and not physical presence of the patient impacted your ability to diagnose and treat? That's a very common question that's asked, is how do you actually examine a patient?
So, well, in regards to our practice, and I could probably speak a little bit for Mark, is that the patients are usually, I guess 80% of our patients are neck and low back pain. So most of the time the patients are coming in, they're being referred from an orthopedic surgeon, a neurosurgeon, or another, a family practitioner. I'd say 75 to 80% of these patients have an MRI, some diagnostic studies. So you can examine you can't physically examine the patient, but you can elicit many of the physical maneuvers that we're taught in medical school and through our residency and fellowship training and as in practice. So, and also you have access to the MRI. So for example, a patient has a herniated disc, they're being referred usually for an injection. And in my case, in my practice, we do a lot of medication management. So it's one or the other or a combination. So you can examine the patient, you have an MRI, you can ask the patient where it is, and you're going to go do that injection in a certain area, which just doesn't require an actual hands-on physical exam. But we usually see most of our consults as an in-office patient, and then the follow-ups are done by telemed.
Right. So a lot of follow-ups.
Correct.
And I think depending on a physician's comfort level, and as they start learning more, they become more comfortable having a patient examine themselves or have a family member help with an exam and be an extension of their hands.
Correct.
Anyway, guys, we're 18 minutes, but it's been super fun. And thank you for engaging with telemedicine and pain management.
Our pleasure.
It's always fun.
Yes.
All right. Bye.
Bye. Have enjoyed the snow.
Yep. Starting to melt.